apologize for not able to make this trip to visit my favorite country for traveling right now because of other research commitment. So, but anyway, today is my great privilege to present the red light therapy for myopia control. This is conflict disclosure, conflict of interest. So when we talk about light therapy or red light therapy, what we talk about is a home use device. The home use device is able to emit laser, low level red light, red laser, low level red light laser, and the device is actually connected to the internet. So when the user use the username, assign username and password to log on the system, and then it will allow you to turn on the light. So this is randomized control trial, 1 year randomized control trial published at the end of 2021 of March. So basically, the clinical trial involved children aged 8 to 13 years old, low or moderate myopia. So what we found is that in this 1 year trial, in terms of axial elongation control, the red light therapy is able to control 70% of the axial elongation. More importantly, the greater level of myopia, like say -3 to -5 darkness, in comparison with a lower degree of myopia, a high degree of myopia could receive a better treatment benefit. You can see from the control and the intervention and the bigger change, bigger difference between the control and the intervention now. So this is against other treatment modality. For example, low dose atropine and autokeratology. Normally, the treatment benefit is less among those with high degree of myopia. Split-cook equivalent basically tell you a very similar story. 80% of the efficacy on controlling progression. Higher degree of myopia receive greater treatment benefit. At the back-end system, we're able to confirm the efficacy compliance on the treatment. So the compliance is greater than 75%. The spherical equivalent progression with the red light therapy is able to control 90%, almost 90% of the spherical equivalent progression. We also, in this randomized control trial, we observe consistently a sustained choroidal thickening in this 1 year clinical trial. And there's no structural damage on the neurosensory layer. So at 24 months, again, this is 1 year trial. At 24 months, we call the patient come back, and then among those children who stop the treatment, we observe a rebound effect. Because the reason we call it rebound effect is that this is the slope on the axial elongation, the change of the axial elongation is greater than what we observe in the control arm. Despite the fact that this slope of the progression is actually very similar to the axial elongation in the first year. There's a rebound. So this modest rebound effect suggests that we should not stop the red light treatment suddenly. We should follow a tempering protocol. So recently we also published a 3-year clinical trial, a 3-year data, real-world data. 3-year real-world data is a multi-center real-world data on the efficacy. But what we observe is that the treatment benefit maintains in the 3-year visit. So we received a similar treatment benefit, and then also the any changes on the axial elongation, axial length has been much thinner. In China, we also combine the red light therapy with autocare. So among those children with poor autocare control, we add the red light in with the autokeratology, and then we also change the autokeratology, the type of OK lens as well. So what we observe is that when you add the red light therapy into the treatment protocol, you can see there's a 100% control of the axial elongation. So by doing so, we achieve a beautiful scenario where the myopia has got 100% control, and then also because of the autokeratology, the children there is we call it spectacle free, meaning you don't need any contact lens correction, You don't need spectacle correction in the daytime. At the same time, we have a 100% SUV elongation controls. And this is an ideal situation for myopia control in my understanding. So there's also some study also try to investigate or look into the scenario where you add IL, the red light, into the DIMS. So this is the DIMS control in terms of axial length changes. This is a 0, no meaning no axial elongation. This is a DIMS control. DIMS spherical control, lens control. It's about 0.1 millimeter, 0.15 millimeter. So when you add the red light to the we are talking about axial sorting, right? Much greater axial sorting when you add the red light with the beams. Which means there's a synergistic effect when you put it beams, lens, and red light together. But this is a very interesting story. They look at the red light treatment benefit among the high myopia. What they observe is that everybody, if you are high myopia, you've got axial sorting. Everybody got axial sorting. Even including the error bar, everybody is less than 0 axial sorting. It's hyperopic. So about 50% of the high myopia children in this trial, clinical trial, got axial shortening greater than 0.05 in a lot of them. So another high myopia trial suggests similar story. Red light, this is red light therapy. Everybody got shortening on the axial length, and there's a hyperopic. Meaning, among these highly myopic children, the red light is able to achieve 100% control, or greater than 100% control on the myopia progression. A study in Shanghai demonstrates among these myopia children, if you use red light, you're able to control or prevent about half of the myopic children becoming myopic. So this is about 50% of the efficacy on preventing the development of myopia among the myopia children. So there's a lot of ongoing clinical trials in China, or I think beyond China, many in Japan, USA, Spain, and so on. So I just want to highlight some of them. So this is clinical trial published in Spanish children, white people, Spanish children. They observed that everybody got axial sorting among the Spanish children. So this suggests a very strong stronger treatment benefit received in the Caucasian or Spanish children in comparison with the Chinese children. This is another Australia college of optometry clinical trial in looking at specifically on the Caucasian Australian. They demonstrate that everybody again got axial sorting. So this consistently suggests that the non-Asian children, like Caucasian children, when they receive red light therapy, they will demonstrate even better treatment benefit in comparison to Chinese children. So this is a Japanese study demonstrating substantial axial shortening among highly myopic children, yes, in a 12-month study, in a single arm study. Surprisingly, this is 2023, study published in 2023. Even in 2023, there's a lot of parallel independent study published. All demonstrate very strong human benefit when the children receive red light. So this is in Professor Jason Yam's study, a major review article. They demonstrate that actually the repeated low-level red light therapy we see at the stronger treatment benefit, very much stronger treatment benefit in comparison with other light therapy, for example, outdoor trial, very mild treatment benefit, but red light therapy we see got a very strong treatment benefit. There's a lot. This is a list of the paper we try to summarize it. There's a more than 20 randomized control trial paper published. They all consistently suggest robust human effect. So a lot of people discussing about the safety of the red light therapy because fundamentally it looks very scary in a way that using laser repeatedly on the retina is a way to treat eye diseases. But we have to looking at fundamental things. First of all, this is first in class, right? First of this kind things like using a laser on the retina as a way to treat myopia or eye disease. But it's very important to understand this is very low level laser. If you look at the 4 millimeter pupil, the laser energy is 0.29 milliwatts. This is extremely low energy on the red light, on the laser. In comparison with this standard treatment, like 400, couple hundred or couple thousand milliwatts, it's very, very low. And that's why we call it low level of red light. And also the device comes with a small computer like this. With the username, password, you are able to turn on the light. So this product design, is able to maximize or ensure the safety when the device is used at home, because you cannot easily turn on the light. The turn on and off follow protocol. You're going to use the username, password to turn it on. So this is the back-end system. Every single device you're able to observe, you're able to see the energy level in every single device. So as the back-end system, we can monitor the real-time monitor the laser energy situation. And this is the red light. The device has received ISO 13485 and also a CE mark approval, meaning the device is allowed to sell in Europe in all the Europe countries. And also the device has been approved in the United Kingdom, Australia, New Zealand, Turkey, Malaysia, and many other countries. We also try to compare the side effect. This is a systemic review with other treatment, low-dose antipianoids. And surprisingly, the incidence of side effect in the red light therapy is extremely low. When you talk to the patient, what's the incidence of red light side effect on the red light therapy? It's 0.88%. So meaning when you treat 10,000 patients, you've got a 9 patient with some side effect. So this is a study interestingly demonstrate on the multifocal ERG. So this is N wave suggesting photoreceptor function and P wave suggesting bipolar or transmission of the function on the retina. So there's no change on the photoreceptor on the multifocal ERG, and actually there's an improvement, getting actually better on the P1 wave, suggesting a better transmission of retina. So there's no compromise on the photoreceptor function. So there's also a study in UK, I think, specifically looking at the color function. What they suggest is that there's a temporary impact on the color function, because after you use a red light, within a couple of minutes there's a change, but then it will return to normal. It return to baseline after 5 minutes. There's no, in other words, there's no other changes after the treatment. This is a very rare case published in JAMA JAMA Ophthalmology Letters in 2023. Reports a very rare side effect. We still observe ISOS disruption right here. So, but then interestingly, Japanese doctors, retina specialists, they share with us. Actually, this is commentary also published in JAMA. You can see when the problem happened, so there's a choroid getting fully dark. You cannot see any choroid right here. But after you stop the treatment, after 3 months, everything becomes normal, and then you can see the choroid again. So the Japanese retina specialist is a night injury expert. They say the patient may be a rare multiple Stargardt disease. With the light stimulation, there's a hypophysin deposition on the RPE layer. So on the top of this, we also learned that this kind of changes is very rare event rate. And also the patient is super responder. So we're very much looking at the super responder. How do you know it's a super responder? Because they got a very strong treatment benefit and also a very prolonged after either 5 minutes or longer. So fortunately, this problem is detectable by real CT and then it's recoverable when you stop the treatment. There's another study published. They report this kind of changes. They call it metabolism deficit. So we understand this is all this metabolism deficit. They come with no visual acuity compromise. So visual acuity remain normal. This is important. This would mean that this observation meaning that this is the byproduct of the light therapy. So, but then it's the byproduct. It's a temporary changes, but then it's also with normal visual acuity. There also a safety interesting study published recently by Lisa Austrian and his group. They're comparing the 4 types of red light therapy devices, specifically on the performing the laboratory testing on the ANSI testing, and then they concluded this the laser device, the device is actually exceed the ANSI safety limit in laboratory conditions. But then, so after publication of Lisa Austin, there's a full laser expert published a separate or published or launch a separate like red light, a testimonial commentary. Dr. Carr is the leading authority on international safe light safety standard. So he's actually one of the members on the ANSI standard. So he's also running FDA accredited light safety lab in Austria. So this Professor John Marshall is an inventor of the laser examination. He's an inventor of the examination and he's an expert on the physician. Actually, he's applied physics expert. He's not a physician, he's a PhD, he's a physics expert. So this is a video, I encourage you to watch on the YouTube, and where they demonstrated very important observation. He said this laboratory, this is a maximum, because the maximum permissible exposure, and this is a established retinal injury. What they say is that actually in the ANSI, this defined maximum MPE exposure is far below the biology safety threshold, which means the ANSI use a very stringent or very or conservative threshold to define the MPE limit. Another point is that is what Dr. Carr and also John Marshall point out. So in this ANSI assessment, they use 7mm as a sensor to measure the exposure. But in reality, in clinical reality, if your pupil size is less than 4.3mm, so this the dose already already extremely safe. In other words, this laboratory testing they use a 7mm. They assume the pupil size is very big. But in the real reality, in the real situation, the pupil size under the light onset scenario is less than 4mm or even 2.53mm. So when you consider the size of the pupil size, and also when you consider the use as intent, the risk of the retinal injury is negligible, meaning that it's very minimal. This is conclusion from Dr. John Marshall's talk, the video. So in conclusion, red light therapy is just very similar to cataract surgery, and no treatment is 100% safe. So as a doctor, we've got to consider the benefit with spatial. For example, in the very young high myopia children, you will receive a lot of benefit and with a very small risk. So it got a very maximum benefit with spatial when you, for example, use it in the red light high myopia patients. So of course, we encourage our doctors to adopt risk minimization strategy. For example, following the consensus guideline, and then also perform fundus examination or fundus photography before the treatment, and then also ideally if you can perform OCT and visual function test, because this is important to observe and monitor the possible structural changes. We also encourage the parents to monitor the warning signs, for example, after image. If the after image is greater than 5 millimeters or 5 minutes, then you've got to pay attention to the maybe the children or the child is super responding to light illumination of that. With that, I would like to conclude my talk, and also thank you so much for your time.